It's a great pleasure to introduce our first speaker, and that's Professor Jamie Craig, who's an ophthalmologist and chair of and academic head of the Department of Ophthalmology at Flinders University.
So thank you very much. It's a great honour to be elected as a fellow, and I particularly want to thank Karen Williams, who nominated me. I'm going to speak about our work in building a polygenic risk score for glaucoma and how we're starting to apply that to patient care to improve outcomes. So science to me is a team sport, and all of what I'm going to tell you has been accomplished by a great team of people around me, many of whom are in Queensland, in fact. My journey began, or the early stages, where I was lucky enough to do a DPhil at Oxford under David Wetherill and Swele Thane. And I think what happens in science is that you learn lessons early and you apply them across your career. So I learned to work on a condition where changing the way that we understood the disease would change the way that you treat patients, and that genome-wide approaches would lead us to understand better quantitative traits in complex diseases. And all of these things I've applied strongly to my directions in trying to get a better understanding of what goes wrong in glaucoma. So what is glaucoma? It's an optic neuropathy where there's gradual loss of peripheral vision and contrast. It's a common disease, and without treatment, it will progress towards tunnel vision, and without treatment at all, total blindness. So we know that what patients fear the most are cancer and blindness, and that makes this a rewarding area to work on. And when I came back to Australia, I worked with David Mackey and Simon Foote, in fact, on the early stages of the glaucoma journey, if you like. It's important to understand that we have good treatments in glaucoma. They're strongly evidence-based, and 70% of patients have raised pressure in the eye, and all of the effective treatments lower eye pressure with pharmacology, with drops, a very innovative and effective laser procedure that's safe. And surgery is extremely effective. And you might ask, why don't we just do that on everyone? It's because it's technically difficult and there are risks involved in doing glaucoma surgery. So you need to apply it to the worst cases. So a couple of other important points. With autism, it's one of the most genetic, complex, common traits in the whole of medicine. About 1 in 30 people at retirement age have it, and that rises to 10% at age 90. And half of the people in our population who have established glaucoma don't know they've got it. So it's asymptomatic in the early stages. So that's led people to I guess, propose that the solution to preventing glaucoma blindness is to diagnose everyone earlier and earlier so they can all be treated early. And the problem with that approach is that you get back to a point where you can't be sure if people even have the disease and before they've lost any visual field, and that's what's known as a glaucoma suspect. So my approach has been to study the very severe end of the glaucoma spectrum and then apply the knowledge to the early stage so that we can bring about translational change in management. And the problem with the approach that has been taken is that we're sort of overwhelmed now with referrals from optometry where they do imaging, find all these patients with possible disease, and that's kind of plugging up the system so that we can't actually manage the difficult cases effectively. But at the same time, we still have people arrive who are diagnosed with end-stage disease. And it's a very unfortunate situation because you can't bring any of that vision back. They basically have to just work with that little bit of vision that's left. It's devastating. So that was my approach, was basically to say, at scale, study those outcomes in our population. And we did that through a population registry, which now has international contributions from places like the UK and Germany, as well as Australia and New Zealand. So we have a large number of patients in this registry now, and they all have detailed clinical information and DNA. And we had very specific and set criteria of what was the visual field criteria to qualify as an advanced glaucoma case. As you can see, we also study secondary glaucoma, which is a lot rarer and very interesting. I don't have time to go into, but particularly the pediatric cases, we've made a lot of progress in discovery there. But we're going to focus on open-angle glaucoma. So once we started to amass hundreds and now thousands of patients in the end stage of disease, we were able to ask some questions about, well, what goes on in these patients in our population? So what are the areas that we would need to address to prevent this problem? So the first point was that the little that was known when we started was there was one dominant gene called mycilin that accounted for some cases. And the question was, how many did it account for? And even in our advanced populations, about 4%. The secondary rarer forms also are very severe, but they together might only account for, say, 10 to 15%. So the 86%, we had no idea at all what the causation of these cases was. So clearly we had to actually go into new strategies to identify what was going on, but we knew it was genetic. So we followed the genome-wide association approach, and with the extreme phenotypes that we had been able to amass, we've been able to, I guess, lead the discovery of the common variants that cause glaucoma, whereas the rare variants have sort of stalled at a few percent. As I said, they're very important, and I'll make a couple of points about that before I go on to the common variant work. We do test all the juvenile cases for these genes, and even the adult cases. Every single one of our cases is tested for mycilin and has a NADA accredited result fed back. And we have genetic counsellor Emmanuel Souzeau, who's a junior fellow in NHMRC. And this is really important, that we want our patients to actually benefit. It's not just a research result that only sits with us. It goes back to the patient and the family. And with David Mackey and Emmanuel, we've got, I think, a world-leading cascade testing program for mycilin through our research-initiated index cases. But it can only really ever prevent that 4% of glaucoma. So it's not going to solve the broader problem. The other thing from rare variant work is when you discover a gene through sequencing, let's say, it could lead to a good candidate for therapy. And so with people like Alex Stewart and Mark Hassel here, I'm showing that this is rodent raised pressure model in Bob Cassin's lab with a gene that we'd found through sequencing. And we've shown that this is neuroprotective to administer neuroglobin. And there's other candidates like brain-derived neurotrophic factor. But I think these things are 10 years from the clinic still. So what I'm going to talk to you about is like ready for airplay now. So we took the open-angle glaucoma cases where we had no monogenic disease, and we basically ran genome-wide association. And this was the start of great collaborations with people like Stuart McGregor and Matt Brown. And our genotyping was done right here on this campus at what was the Diamantina Institute. And we managed to make these discoveries, myself and Catherine Burden, in a lab that's, I like to say it's the size of a broom closet, but that's an exaggeration. It's probably 4 broom closets. And we're only just really getting into a sort of a larger and more modern space. But this was a very effective use of resources because we used the extreme phenotype approach, and we were able to do this with about 590 cases. And I'm going to skip a whole bunch of steps now, but every time we doubled the size of our cohort, we would double the number of complex common genes that we found. So we got to sort of 10, then 20, and then recently, this is a meta-analysis of the consortium that we're involved in internationally with 35,000 cases. And we're up to around 100 common variants that pass genome-wide significance. But the first 2 we found there are still by far and away the main and most impactful, with odds ratios around 1.5, 1.6 each. So together they can shift odds maybe by 3 to 3.5 times for an individual. And that was enough for me to be quite excited about translation in the clinic. But things move very fast. And when the UK Biobank came out, they had intraocular pressure on about 100,000 patients with arrays. So GWAS was able to find another 100 genes for eye pressure. And we're very interested in the cup-to-disc ratio as an endophenotype of glaucoma that may be less influenced by eye pressure, like neurodegeneration. So we graded manually 70,000 optic disc photos to get the VCDR and ran the GWAS and found a whole nother series of genes again for that trait. And that was enabled us to do this multi-trait strategy. So with Stuart McGregor and Alex Stewart and myself putting all these ideas together, we basically are able to meta-analyze for glaucoma status, pressure, and cup-to-disc ratio. So those 3 interrelated traits increase discovery power, so you can end up with a much higher quality polygenic risk score with more discovery in it. So that got us to around 2,700 SNPs in our first iteration of the polygenic risk score. and they're weighted according to the odds ratio. So those first two obviously contribute way more than number 2000, and we're already into sort of second and third iterations of that. So to look at the clinical implications, we go back to our registry and the longitudinal study, and we took out the cases from the generation of the score because you can't sort of do any double dipping. So to show you the data that I'm going to show you, which is clinical significance, it hasn't included them in the discovery for this part of the work. And what we can do is you can shift risk, say in this room, to the top 10% and the bottom 10% just by looking at your saliva or blood. And the difference between the two groups then is something like 15-fold increased risk in the highest risk group, up to 23 for high pressure glaucoma. So I knew that that would be likely to be quite clinically significant, but it's important to point out it's not a diagnostic test. We're not going here, well, you will definitely get this or you definitely won't. We're talking about decision support, and we're talking about risk profiling to enhance screening and management of cases in the community and how often people should be seen and things like that. So to benchmark, we have stronger odds ratios than the other common complex diseases that are being touted for polygenic risk. The age of diagnosis is shifted by a decade in high-risk individuals. It also influences the mycilin gene, so that the rare variant, very similar to BRCA1 and 2 in breast cancer, so the combination of complex common variants and rare variants increases quality of your test. But everything I'm going to talk about now is around just the common variants. We found that patients in high risk have more family members affected, even though family history is a crude measure in the clinic. It correlates very, very well with high polygenic risk. So that has implications not only for the patient in front of me, but also their family and whether they should be screened. And what eye doctors want to know is the patient in front of me going to progress? And should I do an operation that carries risk? And both of those two parameters were strongly associated with high polygenic risk. So to understand that in an individual, the hypothesis behind the progressor study, which was set up to exactly examine this proposition when we found the first two genes, the idea is if somebody had a lot of common variants for glaucoma, they may be more likely to progress, and if someone didn't, that they may be stable. So this patient was, in the mid-range of the ascertainment for progressor, so it's a longitudinal study every 6 months. She was going fine on observation for a number of years and then started to rapidly progress. And at that point, pressure became difficult to control. The steps were put up in the management. She had surgery, and by that time had lost probably half the vision in each eye and 80% of her optic nerve tissue. So following all of that, she stabilized really well with surgery. What's the problem? We should have done it 18 months earlier. And had we known she was in the 96th percentile for risk, we would have managed her differently. And that's how this is going to change practice. So and across the whole study, patients with high polygenic risk showed greater amount of visual field progression. And I think really importantly, in early stage disease, the clinical behaviour of the clinicians caring for the patients when they started treatment and when they escalated treatment to a second or third drop or did laser was strongly influenced by the polygenic risk. So we want this in the clinic. We've done studies and patients want it, and the clinicians want to be able to use this to manage patients more effectively. So how do we do it? We've brainstormed every option and way to go. And what we did in the end was we lodged IP over the actual test. We licensed that. We started a small startup company, and we've basically just said, we're going to do this thing. We have the capacity now to run the test. We've got NADA accreditation. We have a clinician portal, and the initial pilots have been done, and it works and it's effective. So this will be launched very, very soon. These are some just examples of the reporting. It takes a lot of effort to decide how you're going to report this information. And these are real patients. This is a young scientist that I saw recently, had high pressure, came to clinic, no field loss, no disc damage. I would have normally monitored him, and that's what I told him. His results come back at 97th percentile. It's going to change the way I think about his management. This is a patient with early established disease in a high percentile risk again, and we can give information about how likely surgery would be needed to be done for that patient based on our data, which is real world data. NADA accredited with the pathology involved. So who would we offer the test to? Where is the initial sort of people who will benefit? I think the glaucoma suspects, those very early patients, which we're not sure which way to go, how often to monitor, family members of glaucoma patients, early stage glaucoma patients. So that's the initial target. So where are we in the journey? We have the test, we have the NADA accreditation, we have the clinical platform to do it. We obviously would like more evidence around prospective studies showing perhaps if you start treatment earlier, you'll get better outcomes. And to that end, we've got 2 clinical trials that are investigator initiated that are about to start. And one is laser preemptively for people without vision loss who are in high risk groups clinically and with the PRS. And then there's an implementation science study looking at the way patients travel to our clinic from optometry, such that low-risk patients on polygenic risk and clinical will be cared for in the community. They won't get in. The mid-risk ones won't see doctors. They'll just have longitudinal monitoring by paramedical, and the high-risk patients will reach the clinician, the specialist, a lot earlier because of that. The other sort of areas of I guess, blue sky, we're planning to have at least another 3 or 4 tests over the next 1 or 2 years. That's macular degeneration, myopia, and corneal disease, where there's actionable outcomes. And we think with the eye, the great opportunity is to combine imaging for risk for cardiovascular and dementia with the polygenic risk. So we're working hard at the moment to combine the polygenic risk and the clinical data so that we can initiate the studies. And I think that, you know, it will lead to changes in the way that healthcare is done. So I just want to thank very much Stuart McGregor, who works up here in Queensland, who I work closely with, David Mackey, and the junior doctors that I work with who are high degree students and clinicians. And one in particular, Henry Marshall, has just gone off to Cambridge on a Sir John Monash fellowship, and I'm really hopeful that he will pick up a whole lot of great things there and bring them back to us. So thank you.
That was fantastic. And it makes me show how in epilepsy we're still well behind you, and really exciting. So 2 questions. One is, I always think in topiramate, one of the risk factors is glaucoma. I've never seen it. Mm-hmm. Will your PRS help me know which patient not to give it to? Second question, I was interested to hear you've got clinicians actually understanding PRS, because, you know, in our world, it's much earlier than in yours. And I think we're doing a lot of work on PRS, but how do I get clinicians to understand how useful it is to implement? And do you think it's only because you've got much better, I don't know, I've forgotten the higher percentile, to pick your higher percentile?
I get it. The first thing, topiramate's really interesting, but it's a very rare idiosyncratic side effect where you get a fusion. Actually, we wrote, I think, one of the first papers about the mechanism of it, but that I don't know that polygenic risk will actually help in that scenario, because it's going to be a very rare and different mechanism. So I think probably I'll just say probably not. In answer to the second question, education is obviously going to be massive here, because we've worked in this field extensively for at least a decade, and students and people like myself are presenting at our national meetings all the time. The doctors are very much aware that this is about to hit the ground. And I think early on, people are, this will never change anything. 1 gene, it's an odds ratio of 1.5, that's nothing. And then suddenly it's like 15, 23. And I think they know, and when you see the actual clinical data, people want it. Like clinicians actually go, I would want that information. But we're still going to have to do a huge education piece. We're getting all the cases together to show this is what happens in this patient, that patient, how would it change it? And we're doing research on that. So you get a bunch of clinicians look at the baseline data and go, do you think they're going to progress or not? Then give them the PRS as well and see whether they actually do better. So I think it's a big part of it, the education. Thanks.
I'll just shout it out.
Yeah.
On your decile distribution, you clearly got cases who are down in the bottom decile, but they still get glaucoma. How do they differ from the other cases?
Yeah, it's an excellent question, and I think we want to do that as an actual kind of ideas grant or something. I mean, obviously rare variants in theory can be accounting for that, because you have like a rare monogenic variant that we haven't identified or is unknown. and it's still enough to give you disease, even though you had a low polygenic risk. And, you know, I think what the first thing we have to do is just get those patients out. There's not obviously not many of them, but get the advanced patients out that have bottom decile and just start to look at them and go, what's different about you? They have less family history, for example. Some of them may have trauma. For example, if it's one eye, they've been hit in the eye when they were young. To pyramate, you know, I mean, there's all sorts of possible ideas, but I think they'll probably have just different genetics. Like it could be copy number variation. They've got intermediate risk alleles that we haven't yet worked out how to identify, and they might have 10 of those, and that's equivalent to a high polygenic risk. So we're sort of still relatively early in the journey, but far enough to do something with.
Thank you very much.
Thank you.